Tonight we have the pleasure of having Slaven, a medical student from Croatia. He's going to lecture on Kawase approach and temporal approaches. And also we're joined by Simon Downs. Let's first say hi to Simon.
Hello, everyone. I'm looking forward very much to your presentation.
Welcome, Simon. Okay, Slaven, it's all yours.
Okay, we have warm greetings here from Zagreb, Croatia. We are here in the Croatian Institute for Brain Research, and we would like to share with you our presentation on the Kawase approach and temporal approaches. Okay, my name is Slaven Gojković. I'm a medical student here in Zagreb, and I'm also a member of the Student Society for Neuroscience and Neurosurgery here in Zagreb, a great organization which provides students with means of pursuing their interests in the fields of neurology, neurosurgery, neuroradiology, and so on. So it's kind of great organization, and we have such a great collaboration with our professors here who allow us to learn, to study, and to kind of live our own dreams. So, okay, if you like, I can start with today's presentation. We have here also some students from the University of Zagreb Medical School with us in the hall. Okay, so this is just a poster that was made for this. We call it the Rotten course. The Rotten course is a set of presentations which closely follow Professor Rotten distinguished the Rotten collection and his book, Rotten Cranial Anatomy and Surgical Approaches. So we are trying to do our best to study this anatomy, to realize it, and to prepare ourselves for our dream job in the future. So, okay, when we start with the presentation, today's topic will be the temporal bone. Okay. So you know, I think that every person which started to think about neurosurgery felt like this. This is a citation from a book of Professor Šimunović. He's from Sarajevo in Bosnia, and he said this while traveling through the desolation of the human mind. It's just like traveling through the universe. You know, I think this citation, this quote tells the feeling that the person has when he meets with such a wide area of knowledge that he knows nothing about. And this is just the thing that we are trying to solve during our course. We are trying to get the essentials to understand this complex anatomy and how neurosurgery works. If you go on with the slide, you will notice that there was a word navigating the temporal bone. This is not my word. I took it from Professor Rotten, and I think there's a reason. Okay, so this is kind of a clock that we have for our surgical approaches to the skull base. So if we go, we can see here that we have some anterior approaches. This is the most common transclavial approach. This approach can be performed from the nose or maybe mouth. The nose and the nasal endoscopic approaches are most common today, and we will discuss them in the future. Okay, so other approach that we have is this anterior petrosal middle fossa. This is the that we want to know about today. You can see that this approach includes temporal bone, and it includes the most anterior part of this bone. We will discuss this in just a few minutes. Okay, so then we have this posterior petrosal, transtemporal, retrosigmoid approaches that go from the back, far lateral, that are almost so near the condyle that they go right adjacent to it, and then we have the midline posterior approach. Okay, so I think this navigated you a bit like a compass. So you know we are doing now cranial base, and we should concentrate on it, skull base. Okay. So, you know, when I say the term desolation, it looks like a completely defined term. You know exactly what I mean when I say desolation. So let's start with this. Okay. What you see behind me is just a review of anatomy that we will try to see more precisely through the lectures of Professor Rotten. So now I will just review the most basic anatomy of this. What do you think? What is this bone? Temporal bone. Yes. So this course is about this lecture is about temporal bone, and we see here some parts of it. You know, temporal bone consists of five parts. We have here the squamosal part, the mastoid part, petrosal part, tympanic segment, and the styloid segment, which forms bony origin of a bucket of some muscles that go to the tongue and to the mandible. Okay, so we see here another important fossa in which the temporomandibular joint, TMJ, is formed with this. Okay, we can go to the next slide. Here we can see the basic middle fossa exposure. So I think that one of the most important things in learning neurosurgery, the way we were taught to think, is cadaveric dissection. So we are trying to learn this anatomy from a living or dead human being, but from a real anatomy that exists in his skull. So what we see here is the cerebellum. It's in the posterior fossa. This is the margin that forms the boundary of the posterior fossa and the middle fossa. So this is the petrous part of the temporal bone. And we can see here very nicely, I think these are all best pictures that exist, made by Professor Rotten and his residents, but I think this depicts greatly the trigeminal nerve with its three divisions. Okay, so this is the trigeminal ganglion, and then I would just like you to notice this. I don't know if you can recognize this for the first moment, but this is a very important landmark that we have. I'll try to ask my colleagues. Do you see this? What do you think that might this be? Which foramen on the skull base? You can join too if you know. Well, that's the spinous foramen, spinosal, through which the middle meningeal artery rises, and it goes here on the squama of the temporal bone. So I would just like to note that there are some eminences and depressions here. Professor Rotten will discuss this in more detail, and I would just like to say that you see this very shallow bone that looks like a paper. You can see through it. That's the most common site of spontaneous leaks in this area. So you have to be very careful, and if some pathology goes in here and causes infection, it's very important for the inner ear for the hearing to not be damaged. Okay, we can go on. Now we see the same exposure, a bit more dissected. We see here the structures that this petrosal part of the temporal bone contains, and we can see here the nerves in the porous, in the internal acoustic porous. So this is the facial nerve, vestibulocochlear or 8th nerve. We can see here the greater petrosal nerve, which arises from the facial nerve, and the genicular ganglion which it forms. And this structure here, it can be quite easy orient you to where you are right now. This is the carotid artery. Above it runs the trigeminal nerve, foramen spinosum, and this is a muscle. This is tensor tympani, which attaches to the here with its tendon. And we see here the external acoustic meatus, internal acoustic meatus, and here the eustachian tube. Okay, so we can go a bit forward. This is just the same picture to show you where this all was in the petrous part of the temporal bone. We can go on. And now, when we zoom a bit, we can see here more closely the tensor tympani. We see some semicircular canals here and facial nerves. So for now, I think it's just important for you to realize where we are, that we are in the exact margin of the posterior fossa and middle fossa, and we are viewing the contents of the petrosal part of the temporal bone. And someone told that the temporal bone is probably the most complex structure, at least bony structure in the human body, because it contains everything. So many systems are here, so many nerves, so many arteries, so it's very, very complex anatomy. Okay, so when you go on, this is just this exposure that we saw. When these canals are drilled into, you can see that that they are no longer here, and here is the cochlea. So we have drilled into cochlea here to show it. Okay, we can go on. This is just the posterior view of the temporal bone with all the margin. This is the squamosal part, the mastoid part, and we see here trigeminal depression, trigeminal prominence. Then, as we go lateral, we see meatal depression. So the meatus is just under here. So when we look from the posterior fossa, facial nerve, eighth nerve, and intermedius enter this porus here. We will see this in our later slides. And then we have here the most known eminence on the skull base, the arcuate eminence. And then the most lateral, we see tegmen tympani, that paper-thin bone we discussed earlier. Okay. So this is another view, a bit different from another side. You see, we are looking here from medial to lateral. And we can see here the cerebellum. This structure is very interesting, and this is the tentorium. So we see here some of the arteries that go through the cerebellum. This is most probably the anterior inferior cerebellar artery, or ICA. And we see here the carotid, trigeminal nerves, foramen spinosum, and the transverse sinus. So we can go on. Now that we dissect this part, we can see that the anterior part of the temporal bone is almost completely bone. The only structure that we have to have our mind on here is the cochlea. Then here is the porus with the facial nerve, vestibulocochlear nerve, and as we go to the back, there are vestibular canals. So we have to have all these structures in our mind when we consider this area. Okay. So here is the dissection, the same view. We see here all the nerves that enter the internal meatus. This is the cochlea. You can see here clearly the all parts of the cochlea. Then we can see the semicircular canals here under the transverse sinus and cerebellum. You see how tight these relations are, and I would just like you to notice another thing. So if you look at the meatus here, it's very narrow at its tip here to the inner ear. So when we look at this part, it's quite wider. So it's best if you consider approaching this region, it's best to try and approach it from here. And the Kawase approach is one of the approaches which allows you this, and other transtemporal approaches that we'll consider today. Okay, if you go on, we can see now how this looks intraoperatively. So we do a temporal craniotomy. We will see this in a video later. Then we retract the cerebral hemisphere with the dura, and we come all the way down here to the skull base. we see the one of the most important, most recognizable landmarks that we see here is the greater petrosal nerve. We will see this in our next slide. Okay, so this is the greater petrosal nerve that you see on the bottom of the skull base. But you know, when you approach this region, there is a question: how can you orient yourself that you're on the skull base? What do you think that is the most important landmark that you see? It should be something that is so recognizable that you cannot miss it. I think arterial hemorrhage is probably the best way to know this, because when you go through the temporal bone, the first thing you have to do is to peel off the dura, and this takes away with it the foramen spinosum and middle meningeal arteries. So it often needs to be sacrificed here. So the arterial bleeding from the middle meningeal artery is the most common first landmark that you will see on your way. And when you see this, you know that you're in the skull base, and you know that you're in the temporal area, the middle fossa area, and then you're looking for this, the greater petrosal nerve, on the upper surface of the petrosal bone. Here we can see the parts of the facial nerve. This is the tympanic part, the labyrinthine segment. Okay, so we can go on. And now here is just the extension of this approach. When we drill the bone here, we can see this is the greater petrosal nerve, that it gives us kind of wide exposure to this area without hurting any relevant structures. So this is the Kawase approach. This is the approach that lets you come into the middle fossa or posterior fossa through the temporal route without hurting any important structures. Why is Kawase approach so important? Because it preserves hearing. And if you go through the cochlea, transcochlear approach, you need to sacrifice hearing to enter these lesions. I will talk more about Takeshi Kawase later, and describe you how he came to this approach. But for now, just notice these important anatomical landmarks. Okay. And now we see here another important structure that we see, we meet in this area. You can see how many important structures are here. This is the cochlea. Then we see here the fundus of the meatus with its nerves. So this is the vestibulocochlear nerve, facial nerve, inferior vestibular, namely superior vestibular. This structure, you can see it so clearly here, and in operations, it's made. I'm not sure if this is the person that invented the cochlear implant for the hearing, for the loss of hearing, but his name was Bill House, who introduced these approaches, and so this bone is named after him. So this is the Bill's bar, which forms the margin, the transverse margin on the fundus of the meatus. And if you go on, we can see here how the Kawase approach is done. So I'll ask you now, what is this structure? And if you try to orient yourself, you see the cerebellum here. You see the middle fossa here. So what is the structure that kind of makes the slope, the margin of the posterior and middle fossa not so exact? That is the tentorium. So and tentorium kind of makes its way. It continues on the middle fossa. And in Kawase approach, we need to divide this tentorium. There are some very important structures that we need to preserve. This is one of the major veins in this field. This is the vein of Labbé. And we always have to take care to preserve this vein when we try to open this posterior part of the tentorium. So this is posteriorly, this is anteriorly. Then we can retract these parts with sutures, as we can see here. And we need to take care when we cut through the tentorium not to injure this nerve. Well, this nerve goes about the ICA here, and this is the trochlear nerve. So you can see how thin it is and how close it is to the tentorius. So we have to be very careful when going through this area. Okay, so these were all the anterior views of this approach. So now we will discuss very shortly the posterior aspects of this approach, and then we will conclude this with the transmastoid or lateral approach. So we have anterior, posterior, and transmastoid. Okay, we can go on. These are all slides from the Professor Rotten, the Rotten collection, and I'm trying to do this intro just to familiarize you with this anatomy, because many students here said that this anatomy is quite hard for them to get the first time. So we try to pass it like this. I think it's better. Any questions are welcome at any time. So we see here the posterior look at this area. This is the porous of the internal acoustic meatus. You can see here the nerves that enter. So this is the facial nerve 7. Here this is the 8th nerve 8, 7. This is the intermedius. And we see here below all the nerves that enter the jugular foramen. So this is 9, 10, 11. And we see here ICA. This is one of the very important arteries that can make some problems in this area, and we will see it quite more clearly in our next slide. So here in our next slide, we can see some other parts of the cerebellum. This is the choroid plexus, which arises from the lateral recess that opens here on the anterior side of the brainstem. This is flocculus, one of the most one of the prime lobes of the cerebellum. And while cerebellum develops, it extends in its size, and it pushes the flocculus all the way to anteriorly. So we can orient ourselves with these structures, with flocculus, with choroid plexus, to know that this is the lateral aperture, and this is the 7th nerve that arises here. 7 and 8 go exactly about below flocculus, and this is these are the nerves of the jugular foramen, 9, 10, 11. Okay, and now we can see here these arteries that like to loop into the pores of the meatus. So it's very, very important to keep this in mind, and to be very careful when you are drilling out this bone to open the meatus. This is just the dura, which covers the nerves. Okay, and now another important structure that's on your way, except for this ICA loop, is the nervus intermedius. It can be made of as much as 6 bundles, and I recommend warmly the chapter on these approaches in Professor Rotten's book, Cranial Anatomy and Surgical Approaches, because I think that it really says everything there. How much of these rootlets can be, in how many cases, how long they are, what is the most common flow of them in this area, and so that's a great resource for any kind of anatomy, and I'm sure that experts are familiarized with this. And this is the Bill's bar we talked about. Okay, so when we go on, we can now see this area to which we can get through the transtemporal approaches. So these are very important structures that we don't want to touch. This is a structure that's very interesting. This is dura that makes it to look so white. And you see here in the pores how many room you have. I want you to just to remember this, because it is far more easier to go from the medial to lateral than from lateral to medial, because if you go from the lateral, which kind of makes more sense when you operate from the lateral part of the head, but you are getting into danger to injure these nerves. So you should always try to go from medial, and this is the recommendation of Professor Rotten that I like to to point out. And this is another important structure. This is the jugular bulb. So you know, if you open this, you get so vast venous bleeding that it's very hard to operate in this area. Okay, and now we are just in our uh, in a part where we go from the lateral. So let's view these approaches. So this is the mastoid process here. This is the porous of the external acoustic meatus. We see here the carotid artery, jugular vein, and this is the place where the sternocleido the muscles attach. So when you go on, okay, we see here the exposure that we get through the mastoid process. So we can see here the semicircular canals, we can see the dura and the venous structures that are here. So this is quite wide of exposure. And if you go on, you can see here the middle ear and its contents. So these are the ossicles in the middle ear. We can see some nerves and the semicircular canals here. So this is posterior, this is anterior. Okay. Just a bit more of these ossicles. Professor Rotten will discuss this, so I will not go into more detail here. Okay. And now, when we see here, we see the muscle here. We see the mastoid process. We see the skin of our wound that was confronted anteriorly. And now, when we go to this mastoid part, the first thing that we can expose as we come closer is this. This is the cellular or the airy vacuoles that are here in this area, and we can see all the ossicles and nerves when we go down. Okay, so these are just these cellulae mastoideae, as we call them in Latin. Okay, and finally, when we come, we see wide approach of the middle ear and some structures of the inner ear. So this is an exposure that brings you directly where you want to be, and I think it is very convenient for some operations where you need to do something with the ossicles or partial labyrinthectomy, for example, where you have to remove some of the semicircular canals, but not all of them, and this can lead to some preservation of hearing and balance. Okay. So this is just another view to show you how wide this exposure is, and finally, when we see here, we have exposed the complete posterior fossa. So you can come all the way from the surface to the intracranial fossa and expose all the important structures that you have here. This is the CP angle. So we see here the structures that enter the internal acoustic meatus and the great venous parts of this posterior fossa. Okay. And these pictures show this just in a little bit more detail. You see how complex this anatomy is, and so I would like to now give her to Professor Rotten, and we will view the Rotten collection to get the expert speaking about his slides. Okay, let's just see some more pictures. This is the exposure intraoperative, how it's done. You place your retractors. Then you open the dura, okay? In this fashion, Y-shaped opening. We see here the sinuses, okay? And it brings you here to the CP angle, where you can view all the nerves that arise from the CP angle and go to the foramens, corresponding foramens on the skull base, okay? And this is transverse sinus. You can retract it. You need to take care not to injure it, and cerebellum and all the other structures. It we can see here. So these are just some of the you know, when the first time we had this course, and I tried to introduce students, my colleagues here, with Professor Rotten's videos. They were so amazed, and they found it so complicated to understand that I kind of heuristically put this in. These are the words of Leonard Cohen. Follow me, the wise man said, but he walked behind. So I didn't want people to feel like this. So this introduction was because of this. And now we can view these videos.
This lecture will review the approaches to the temporal bone as seen through the middle and posterior fossa and from laterally through the mastoid. We will begin with the approaches through the middle fossa. How many parts to temporal bone? Anyone? What part of temporal bone is this? Forms floor of middle fossa, lateral wall of middle fossa. Anyone? Squamosal part. Posteriorly is mastoid part, petrous part medially. Tympanic part here forms the back wall of the condylar fossa and the lower and anterior margin of the external canal. And the fifth part is the styloid part. We'll talk more about this tomorrow, but all of you have had a little introduction to this. We're looking at floor of middle fossa. We peel the dura back to the petrous ridge. Where is the cochlea?
B.
Everyone. At B here, in back of the greater petrosal nerve, just distal to where it exits the geniculate ganglion. Now, cisternal, meatal, and then from fundus to geniculate ganglion, what segment of facial nerve? Labyrinthine. And distal to that is tympanic segment. Now, where are you going to drill if you're coming through the mastoid from lateral to open the superior vestibular area, the fundus of the meatus? Where do you drill? At A. We said all the canals, the three, have an ampulated and a non-ampulated end, and the ampulated end of the superior and lateral canal is anterior, and so when you drill through this area, you'll expose superior vestibular area when you're coming through the labyrinth. And inferior vestibular area, you're going to drill at the lower end of the posterior canal at D to expose inferior vestibular area, and the common crus is going to be located at B here, where the back end of the superior and the up end of the posterior canal join. So as we look at middle fossa, medially you have trigeminal impression, and then it rises up to a prominence that we call the trigeminal prominence, and then it sinks down again into a depression above the internal acoustic meatus. We call this the meatal depression, and then it rises up at the arcuate eminence, and lateral to the arcuate eminence is this paper-thin bone that we call the tegmen, and it roofs the external canal, the tympanic cavity, and the mastoid antrum, all set below this paper-thin bone that is the most common site of spontaneous or postmastoid leaks into the middle ear. And here we see the greater petrosal nerve, and under it is the carotid artery. Usually the carotid lateral to the trigeminal nerve is covered by bone, but in about 15% of cases there will be a dehiscence of bone over the carotid artery lateral to the trigeminal nerve. So now we've drilled out the middle fossa. We see the mastoid, the external canal, tympanic cavity, internal acoustic meatus, and the area along the carotid. And is the cochlea going to set at A or B? It's going to be at B. So a way of thinking about this area is to think about it as what I call the rule of Y. External canal is one limb, internal canal the second limb, and the eustachian tube is the third limb. And along this anterior limb of the letter Y is this structure, which is the, anyone? In the roof of the eustachian tube, nestled up right against the carotid, separated from the carotid by a little thin shell of bone, is the tensor tympani, innervated by the facial nerve. Yes? No? Five innervates the tensor tympani. So you have tensor tympani, eustachian tube, greater petrosal, and carotid, all oriented along that anterior limb of the letter Y. Setting at the junction of the three limbs is the tympanic cavity, incus, malleus, stapes, here in the tympanic cavity, and then also wrapped around the junction of the three limbs is the cochlea and the vestibule, into which the semicircular canals open at this junction. So here we're looking at the junctional area, superior, lateral, posterior canal, tympanic cavity, tensor tympani. Is cochlea going to be at A or B? It's going to be at B, and this is facial, this is superior vestibular, inferior vestibular. And here we see the cochlea. The basal turn sets in this cochlear angle. The middle turn, the apical turn, comes forward under the greater petrosal nerve, is nestled right against the back of the tensor tympani. And coming through the middle fossa, you can drill out three approaches. One goes to the internal acoustic meatus that's hidden here behind the superior canal. The second comes through the petrous apex, under the trigeminal nerve, down to the side of the inferior petrosal sinus, adjacent to where the sixth nerve passes through Dorello's canal. And when you're drilling medially through the petrous apex, it's easy to have spread of heat to the sixth nerve. I've seen a number of transient sixth nerve palsies from spread of heat to that nerve at the medial part of the anterior petrosectomy. The third approach you can take through the middle fossa is an extended middle fossa approach where you can expose and drill out the labyrinth to get into the posterior fossa. So here we're just looking now at the facial nerve, geniculate ganglion, greater petrosal, cochlea setting in the cochlear angle, and behind is the vestibule into which the three canals open. And if you're going to the internal acoustic meatus through the middle fossa, the drilling is very tight at the fundus of the meatus. If you get a millimeter off target and drilling out over the labyrinthine segment, you get into the cochlea or the vestibule, and hearing is lost. And usually in these approaches, they're designed to preserve hearing. And here between the facial and superior vestibular is the Bill's bar, the vertical crest, named for Bill House, who introduced this middle fossa approach. Now, if you look at the area of the porus of the meatus, there's lots of room over the nerves at the porus. It's very tight at the fundus, so that when we drill out the internal acoustic meatus, we start today, well, in the past, they followed the greater petrosal to the labyrinthine segment, very tight drilling, easy to enter the cochlea, and then work toward the porus. But today we've learned it's best to work from the porus to the fundus of the meatus, that there's lots of room around the nerves back here below the petrous ridge, but here at the fundus, the geniculate ganglion is just below the floor of the middle fossa. Sometimes it's even exposed in the floor of the middle fossa. But to get to the nerves in the porus, there's quite a thickness of bone below the petrous ridge, so that when you begin drilling at the petrous ridge, above the porus, you have to go through a lot of bone to get down to the dura around the nerves at the porus. But then as you work toward the fundus to expose the meatus, you're coming progressively more superficial, and the labyrinthine segment is just below the floor of the middle fossa. So that if we look from the back at this temporal bone, what is this depression? Trigeminal, and this is trigeminal prominence, meatal depression above the internal acoustic meatus, and then arcuate eminence, and this area is tegmen. So at surgery, we're usually elevating this dura and looking at it upside down. And here we see the greater petrosal, Kawase's triangle, trigeminal depression, trigeminal prominence, meatal depression, arcuate eminence. But if you look at the external canal here and sight down it, that's going to be almost directly in a line with the internal acoustic meatus. The other way of citing how to drill out the internal acoustic meatus is to take and create an angle between the greater petrosal and the arcuate eminence. That angle is usually about 120 degrees, and then you bisect that angle and you lock the retractor on top of the petrous ridge, and you begin drilling here above the porus, which is deep but wide, with lots of rooms around the nerves, to the fundus, where the nerve is going to be very superficial, but the drilling is going to be very tight. So we've drilled now from porus to fundus. We see here what segment? Labyrinthine segment. And so that we can drill 3 approaches, one through the petrous apex, one to the internal acoustic meatus, the other drill out the labyrinth and do an extended middle fossa approach. So here we've now drilled out medial to the meatus, the anterior petrosectomy approach, down to the clivus and the inferior petrosal sinus. We see the ICA, the 6th nerve medially, in the anterior petrosectomy approach. This is what nerve? Passes under Gruber's ligament, that's 6th, 4th, 3rd nerve, running above it, PCOM, superior cerebellar artery, ICA. So you want to have all of these relationships. So now you can expose this area of the middle fossa through an OZ for just going to the middle fossa approach to the meatus or the anterior petrosectomy. We can do a temporal craniotomy centered above the posterior root of the zygoma. We elevate the dura, and here we see greater petrosal. Now, when we're exposing the triangles in the cavernous sinus, we peel this dura backwards, but if you're peeling from front to back at the greater petrosal, it's easy to get under the nerve and avulse it. So when we want to expose this area in the greater petrosal, we get in posteriorly, we elevate this dura forward, and usually that dura peels up off of the greater petrosal nerve, and in about 16% of cases, lateral to the trigeminal, we see the geniculate ganglion exposed under the dura in the floor of the middle fossa. And not only is the ganglion exposed, but you see some of the, what segment? Labyrinthine, and here tympanic segment exposed under the dura. So you want to be very careful in this area. If you're going to do just an approach to the internal acoustic meatus, you can often save the middle meningeal artery, which does send some blood supply to the facial nerve. But for drilling out the anterior petrosectomy, we usually need to sacrifice the middle meningeal artery. And so the 2 most common approaches that we take to this area are either the approach to the internal acoustic meatus, bisecting this angle between the greater petrosal and arcuate eminence that overlies the superior canal, and we begin drilling at the petrous ridge and work toward the fundus. For the anterior petrosectomy, we drill medially under the trigeminal nerve down to the side of the clivus. And here we've opened the meatus, working from porous to fundus, and this is what nerve? Facial, cochlear, intermedius that could be made up as many as 4 bundles, superior vestibular, inferior vestibular. Okay, well, everyone passes that course, and this just shows you at the fundus how close the cochlea and the vestibule are. Facial nerve, superior vestibular, cochlear, inferior vestibular, and this is Bill's bar, and this is transverse crest at the fundus. So the anterior petrosectomy approach, we drill medially to the porus, behind the greater petrosal nerve. The carotid, if you drill this bone, you'll find it just under the greater petrosal nerve. You drill under the superior petrosal sinus, down under the third trigeminal division, to the side of the clivus, along the inferior petrosal sinus. And then you open the temporal dura and divide the superior petrosal sinus, and then you divide the tenth. So the approach looks something like this. You open the temporal dura and elevate the temporal lobe, always taking care to preserve labbe. And then we divide the tenth, taking care to preserve the fourth nerve at the medial edge. And it gives you this approach to the anterolateral brainstem. You have exposure above and below the trigeminal nerve, and it delivers you down to the side of the basilar artery. So some surgeons, if they're going to go to a low basilar bifurcation, do transcavernous approach through the clinoidal and oculomotor triangle, and others do an anterior petrosectomy that opens up this area between the pons and the clivus to reach a low basilar bifurcation. And what nerve is this? Sixth nerve, passing below Gerber's ligament. So this is just another one of these exposures. Internal acoustic meatus, facial nerve, the labyrinthine segment, tympanic segment, greater petrosal nerve, the cochlea. I'll even buy 3 cups of coffee tomorrow at breakfast for anyone that can expose the basal turn, the middle turn, and the apical turn of the cochlea in this cochlear angle. And now we view the approaches through the posterior fossa. Just looking at porus, we see 7, 8. We see subarcuate artery, labyrinthine artery, facial nerve in the infrafloccular position, Luschka. We drill off the meatus. To drill off the meatus, you usually have to sacrifice the subarcuate artery, but it ends blindly in bone. In about half the cases, the ICA will loop into the porus. And here we've opened the dura. We see 8, 7, and rootlets of intermedius. Sometimes the ICA can loop all the way to the fundus. And here we're looking in from the back, and this is Bill's bar, superior vestibular, the inferior vestibular, cochlear, facial, and intermedius. So now, if you drill lateral to the porus of the meatus, you can, if the pathology goes into the vestibule or the canals and hearing is lost, you can drill all the way lateral into the vestibule. And what is this? What is that prominence? Arcuate. And what canal is that? Superior. And this is the canal of the posterior fossa, the posterior canal, the canal of the middle fossa. What did I drill into here? common crus, the junction of the back end of the superior canal and the up end of the posterior canal. And you can drill into it then, common crus, or you can get into the endolymphatic sac. Here we see the hiatus, and it sets in the dura on the back of the meatus. Someone or a lot of you are going to get a piece of rubber dam into the endolymphatic sac. Sigmoid comes down, and then what turns up under the labyrinth in the infralabyrinthine position? The jugular bulb sets here. So that here we see the hiatus of the endolymphatic sac. It sets in the dura here in the hook of the sigmoid. When you expose, if you're wanting to avoid it, why, you can feel the endolymphatic sac. In this area, the dura, if you feel through the dura is going to get a little softer. And then this area under the labyrinth, if you drill this out, you see the jugular bulb here in the infralabyrinthine position, so that we've exposed the jugular bulb here. It can even extend into the posterior lip of the meatus. And this is the, this is the vestibular nerves. What nerve? Cochlear, facial, and the canals are here, and below the fundus of the meatus, the vestibule opens into the cochlea that sets here adjacent this lateral bend of the petrous carotid, and it sets in that cochlear angle. So here we've drilled out the labyrinth, and the vestibule opens below the fundus into the cochlea, and this is going to be facial, Bill's bar, superior vestibular, the inferior vestibular, and this is the singular branch of the inferior vestibular that innervates the ampulla of the posterior canal. And what canals does the superior innervate? The superior and lateral canal ampulla, and this is the oval window in which the stapes sets. So you're looking at the fundus of the right meatus, Bill's bar, facial, superior vestibular, the inferior vestibular, cochlear, singular foramen for the branch of the inferior vestibular that goes to the posterior canal ampulla. And now we will review the approaches from laterally directed through the mastoid. So everyone passes that course. Course of facial nerve. A, deep to the spine of Henle. Mastoid antrum that's lateral to the labyrinth at A. And here we see sigmoid, jugular bulb, infralabyrinthine, tegmen, middle fossa, superior petrosal sinus. What do we call this angle here? Sinodural angle. You want to see your sigmoid, and working in this area, it's going to be easier if you just get behind the sigmoid. It makes things easier to pull away. And our labyrinth, this is the facial recess, and above is the fossa and cutis. You always see the short process of the incus pointing toward the tympanic segment of the facial nerve, which passes below the lateral canal and then downward. So the labyrinth, this is superior. And you see how this lateral canal, the posterior canal, wraps around it. Half is below, half above. And where is the facial nerve? Well, the answer is facial nerve along this area. Where's the common crus when you look at it lateral? C, at the back end of the superior, up end of the posterior, superior vestibular area. At the anterior end of superior and lateral canal at A. Drill damage to facial nerve. At D, you could also get it if you drill on the medial to the upside of the superior canal. You can bag the geniculate ganglion in that area. So we always drill lower side of superior canal, upside of lateral canal first. Stapedial muscle attached to the neck of the stapes. And this is what recess? Facial, and this is fossa and cutis. Oval window. Here's where you thread the cochlear implant. You work through the facial recess, you look through it, you see the round window and stick a little wire up in there for a cochlear implant. So, and this is the endolymphatic sac, worth a few cups of coffee there. So here's just a approach through the mastoid then, and sigmoid, sinodural angle, middle fossa plate. What canal? Posterior, wrapping around the back part of the lateral canal. This is the spine of Henle. Okay? This is tympanic cavity, chorda tympani crossing inner surface of tympanic membrane. What is that? That dark hole. It's eustachian tube, so that often when they drill out a mastoid, a translab, to prevent CSF leak, they'll plug the eustachian tube. Since hearing has been lost, and here we have malleus, incus, stapes, short process of incus. You can use it as a landmark. It always points to tympanic segment of facial that turns downward below which canal? That's lateral canal. This is the posterior. And then you don't see superior until you work medial over the top of the lateral canal. So here we just see lateral canal. This is facial nerve turning downward, the short process of the incus pointing toward this tympanic segment of facial nerve, stapes setting in oval window. And here we've drilled out the canals. We've saved the anterior end, the ampullated end of the lateral canal. And the facial nerve tympanic segment passes just above the stapes setting in the oval window, stapedial muscle, and then here is that ampulla of the lateral canal above the facial nerve. So you want to drill that upside of the lateral canal first, so that spine of Henle is here, external canal, mastoid tip. You drill through this area where the mastoid antrum comes into view, and facial nerve. This is chorda tympani, facial recess, fossa incudus, and you drill this. Commonly there's a little bridge of bone from the anterior edge of the lateral canal across to the posterior canal wall, and that's called the buttress. Some of you'll drill it and see the buttress, and then that comes out last, and it communicates the facial recess and the fossa incudus. And then the deepest canal is the superior. This is lateral canal with a posterior canal wrapped around the back end of it. The facial nerve turning downward below the lateral canal. And the view again, superior, lateral, posterior. Here we've exposed the endolymphatic sac, and you can get into the sac retrosigmoid, or you can identify the sac presigmoid in this retrolab exposure. Now you can do a partial labyrinthectomy. If you take out the superior canal, it increases the access to the middle fossa, and if you take off the posterior canal, it gives a little increased access to posterior fossa. If you plug these openings, you can save hearing in about half the cases. If you get into the lateral canal, it's hard to preserve hearing. But you can do a partial labyrinthectomy. And here we've taken out the lateral canal. We still have the ampulated end of it here at the superior vestibular area preserved. And then you drill out the labyrinth that gives you access to the internal acoustic meatus. If you need just CP angle here, you can do retrolab, but to get the nerves in the meatus, you need to drill out the labyrinth. This is 5, 7, intermedius, 8, 9, 10, 6, motor 5. It arises around the superior medial side of the sensory root, sometimes 5 or 6, 7 rootlets coming into the brainstem, superior medial to the sensory root. And here we just see the tympanic membrane, chorda tympani. What segment of facial? Mastoid, tympanic, running above the stapes, setting in the oval window. And here's the geniculate ganglion here. If you want to move a facial nerve, then right here is where the greater petrosal nerve arises. If you divide that, you could move the facial nerve posteriorly like this to get in for a transcochlear approach, but that always results in a temporary, complete facial palsy that rarely or uncommonly recovers to better than a grade 3, which is some eye closure. So once you work around or move the facial nerve back, you can get into the petrous apex, into the cochlea, drill it out in a transcochlear approach, and that delivers you through the petrous apex, below 5, down to the side of the basilar adjacent 6. The exposure looks like this: side of clivus, inferior petrosal sinus. Facial nerve is folded backward. This is 6, passing through the inferior petrosal sinus, 5 here. And then you can combine that in the presigmoid approaches with a temporo-occipital craniotomy. Here we've drilled out the labyrinth. We see what canal? Faces middle fossa, temporal lobe, superior, posterior, lateral, endolymphatic sac. And in this approach then, we open the temporal dura, divide across the superior petrosal sinus, down across this dura between the sigmoid and the labyrinth that we call Troutman's triangle. You usually divide through the endolymphatic sac, and this is the posterior fossa exposure 7, 8, 9, 10. And then we divide the tent. We see 5, motor 5, 7, intermedius 8. And then you drill out the labyrinth. You have access to the meatus. Always when we divide the tent, we want to, and open the temporal dura, we want to preserve labet. It's an important consideration in planning these approaches. And then in dividing the tent, we always want to preserve fourth nerve. This is a translab exposure. And then you can move the facial nerve posteriorly, drill out the cochlea. You're down to the side of the clivus, the inferior petrosal sinus, sixth nerve, basilar artery, fourth nerve, third nerve. So just a view of the ossicles. This is, what is that? Well, that's the pedial muscle, the tendon attached to the stapes. Now you're sitting inside the vestibule. We pull the stapes out of the oval window. You're looking out at the inside of the tympanic membrane, facial nerve. What segment? Labyrinthine, just before the geniculate ganglion, tympanic segment, mastoid. What is this? Tensor tympani. It attaches to the malleus, and then crossing the inner surface of the tympanic membrane, chorda tympani. Well, I know that took a long time. I hope it got you oriented to some of the things that we're going to be doing. Thank you.
This is Ricardo Komatar, Christopher Kellner, and Mark Otten, in conjunction with Sander Connolly, leading you through a terional craniotomy. The patient is positioned supine with their head turned, slightly extended, and elevated. Cranial fixation is obtained via a Mayfield clamp, with 2 pins placed low on the occipital bone and 1 just contralateral near widow's peak. Perioperative antibiotics are administered, and the frontotemporal region is then shaved with a skin incision marked from widow's peak to the zygomatic arch. The surgical field is then prepped and draped in usual fashion, including sterile towels, IABAN, and a craniotomy drape. A linear incision down to bone is made, starting at widow's peak and extending to the superior temporal line. Rainy clips are placed to reduce scalp bleeding. The skin and soft tissue from the superior temporal line to the zygomatic arch are then carefully incised and divided down to the temporalis fascia so as to preserve the superficial temporal artery. Again, Rainy clips are applied to reduce scalp bleeding. Temporalis fascia is then sharply cut, and the muscle elevated forward using a combination of blunt dissection with the periosteal elevator and cautery to disconnect from the superior temporal line. Once reflected anteriorly to expose the orbitozygomatic arch, heavy vicryl stitches along with rubber bands attached to a lalabar maintain exposure. The planned craniotomy is outlined, and an initial burr hole is placed low in the temporal region where the bone is thinnest. A high-speed drill is then used to perform the craniotomy. The bone flap is carefully elevated to preserve dural integrity, and the sphenoid wing is flattened using a combination of pneumatic drill and rongeur instruments. The bone edges are waxed, dural tenting sutures are placed, and meticulous hemostasis is obtained. The dura is opened posteriorly using a 4-0 silk suture and 11 blade, and this opening is then extended across the sylvian fissure with long straight scissors cautiously so as to not injure the cortical surface or vasculature. The dural edges are tented over cottonoids to maintain a dry operative field. Wet sponges and towels are placed at the edges of the surgical domain, and the Greenberg retractor system is assembled. Telfa is placed on both sides of the sylvian fissure prior to bringing in the operative microscope. The bone flap may be reattached in numerous ways at the conclusion of the operation. Our preference is to use metallic implants with a small link placed over the keyhole, a gap plate over the sphenoid wing defect, and 2 long links posteriorly to obtain solid 3-point fixation. Closure of a pterional craniotomy begins after meticulous intracranial hemostasis is obtained. At this point, a primary dural closure is attempted. The dural stay sutures are cut, and a cottonoid is placed on the brain surface below the dural edge to prevent blood from collecting in the subdural space. 4-0 silk sutures are placed in an interrupted fashion, beginning at the most dependent portion of the durotomy and continued until satisfactory dural closure is obtained. The subdural space is filled with irrigation prior to the placement of the final dural stitch. Any discrete bleeding on the dural surface is handled with bipolar cautery and a thin layer of Surgicel. Likewise, epidural bleeding is stopped with a combination of flow seal, gel foam, and bone wax. A central tenting stitch is placed, and a dural substitute is laid over the dural surface. The bone flap, constructed as previously described, is then set in place. The subgaleal and temporalis retaining stitches are cut, and muscular bleeding is identified and precisely cauterized. The wound is generously irrigated to remove debris and devitalize tissue, and at this point a subgaleal drain may be placed at the discretion of the operating surgeon. The temporalis fascia is reapproximated with 2-0 or 3-0 interrupted vicryl stitches. The scalp is closed with 3-0 vicryl stitches at the galeal level and staples to reapproximate the skin edges. The wound is properly dressed with bacitracin ointment, sterile gauze, and a head wrap.
Thank you. Again, this is how it's placed in real life in surgery, and obviously the malar eminence is the highest point to allow the frontal lobe to fall away and minimize aggressive retraction. Depending where the lesion is, the head is turned differently. The more closer the lesion is to the midline, such as an anterior communicating artery aneurysm or a paracellular meningioma, the less turn of the head you need to approach the lesion. The more away it is, such as an MC aneurysm, the more turn of the head you require.
So what I would say on that slide, if you want to go back one, but I agree with your positioning. So I think of it in terms of 3 steps. One is to lift the entire head up so that they're extending their neck forward, then extend the neck and then rotate. and that brings the malar eminence to the highest point, but it also brings the area that you want to approach, the terional area, right up in most easily accessible position. You don't want a situation where the head is kind of down below the table. You want it up in front. You want their neck somewhat forward, rotated, and extended. And I think of it exactly in those three movements. Lift the head up, then rotate, and then extend. And then that maximizes your optimal exposure here.
This is a patient of yours, 47-year-old male, or actually this maybe the pictures are a different patient, but the video is essentially approaching a very same lesion. So 47-year-old patient with bilateral visual dysfunction was noted to have a large craniopharyngioma and also frontal symptoms. And I think we'll go ahead and review the positioning for the patient, please. Can you please take us through this, Troy?
So again, this is not about right or wrong. This is just another way to do it compared to the drawing. So I prefer, from the root of the zygoma, to make more of a C-shaped curved line like this, rather than the alternative of bringing it across over to the other side. And I think you can just get this a little lower here so that this line is closer to the keyhole, which is here, and my line crosses here. So you don't have very much to pull the skin down to get to that keyhole. It just has worked for me. And this is a hair-sparing approach. You don't necessarily need the strip to be this wide. You could make it a little narrower, but even preserving this much hair, at the end of the procedure, the patient will be able to cover this completely, and really no one's going to be able to see this. You can see the position of the pins. As I said, one hole off to the opposite side, as far lateral as you can make it without sliding off the edge. Two pins right in the back and the middle. And again, the purpose is only because I use the Buddy Halo retractor or the Doro retractor, and the clamps go on each side of here, and the ring is going to be centered on my craniotomy.
Thank you, Troy. And I think this is another view from the lateral side, if people are interested.
Same point. The only other point I'll make here, and I guess I told you the 3 steps: lift the head up, extend it, and rotate it. The other thing you'll see slightly here is that I tilt it slightly to open the angle between the shoulder and the head. You don't want this tilted toward that shoulder, or you're going to be cramped in your working space. And so there's a little bit of tilt at the end just to get a little wider working space right here, and it gives room for an assistant to be on your right side to help you during the surgery if you need it.
Thank you. Let's go ahead to video now and review the details of one of your patients' video. Thank you, Troy. So, Troy, let's go ahead and review this right frontal terional craniotomy, and please take us through the details.
Okay, so we can see, and I'll start the video. Let me qualify this by saying that this is the way I do it. I am not claiming that this is the only way to do it. It works for me, and there are several important points about this. As you will see when I go through this, I do a terional craniotomy in a stepwise fashion, and I use the same instruments in the same order every time. It is very consistent, and when you do that, your scrub nurse is going to be much better at helping you, because she's going to know exactly the order and routine of the instruments, and you are going to get to a point that you can do this very quickly and save your time and energy for clipping the aneurysm or taking out the tumor or whatever you're targeting. So, very compulsive about this. First step, we talked about minimal hair shaving. Watch how many staples I'm putting in here. I do not want hair getting into my wound here, so I am going to staple this go a bit overboard. I put one towel here, and again, I'm very compulsive. I do it the same way every time. right to a T here, and then I have the towel on the incision, pull it back with the hair, and keep it there. I remember I have the front of the Mayfield clamp here, and I'm stapling that out of the way so it's draped out of the field. That's 2 towels, and there's going to be a 3rd towel. And again, compulsively keeping the hair out of the field. There's nothing worse at the end of a case when you're closing and you're pulling all these hairs out of the wound. You're going to get infections. Leave yourself enough room. Again, this is subtle, but at the end, leave yourself a wide enough space here to staple the incision closed without stapling the towel into the skin incision. So we'll see that at the end. I referred earlier. The assistant has the suction and spreading the fingers and holding pressure. Not so much pulling back, but pushing down. And when you do that, there's minimal bleeding. And you see here that we can make a smooth cut. And I talked about saving the STA. And there I've opened the galea, and there's the STA. I can see it, and I can cut right down on it without cutting it. Keep pressure on the edge of the incision. Already, I use my Rainy clips as a reinforcement to hold that towel to the scalp. Keep the hair out of the wound. There, I opened the temporalis muscle with the knife. I would have preferred not to do that. So the Rainy clips, you see, some people put them very flush together. I have no problem leaving a little space between them. I've made one cut coming up to here, and I'll make my second cut from the beginning. My fingers can spread that length all the way to bone. This part is not over the temporalis muscle. You want to be as perpendicular. That was sloppy right there. I'm criticizing myself. I should not have that little flap of skin there. It should have been straighter. But you want to connect those 2 incisions, or you connect that line to open this flap, and then put your Rainy clips the same way. But you see we made one cut coming up and one cut connecting it. As wide as our fingers can spread, that covers the length of the incision that we can open at a time. If you do this, there's really very minimal bleeding. I like to raise this flap in 2 layers, and I use a scalpel to make sure I stay in an avascular plane. I'm not burning anything, so I don't use the bovie for this. And it's a sweep. I always use the blade, belly of the blade toward me, and I come right down there to the root of the zygoma, and I focus on the frontal side up here. I undermine that right there. See, undermine right there to get down to the keyhole. The fat pad we talked about is down here. You don't need to dissect so much because your temporalis muscle is going to come up with this flap. Stay out of that fat pad. Right here, my thumb, I'm feeling the keyhole. I know I'm anterior enough. I put a rolled sponge behind the flap, and I use fish hook. It's the same way every time. My first fish hook goes right at the keyhole, and then I'm going to put a second fish hook on the frontal side. And once we get that fish hook there, then I'm not going to put a fish hook right here because it's a wasted step. I'm going to open the temporalis muscle, reflect it over here, and then I'm going to retract both with one fish hook. I don't need a fish hook here yet. So now I've got 2 fish hooks. I use a bovie. I come through this. I open the temporalis fascia. I don't go all the way to bone right here because I don't like bleeding. So I go through it in 2 layers. I go open the temporalis fascia. Here I go to bone, opening the periosteum. Here I'm staying very low, frontal, as low as possible. Now I'm going to come through here. There's commonly a vein that you'll get into right here, but if you're careful, you can save it. Or at least coagulate it. I don't mean save it, but you can coagulate it without getting bleeding started. Feel the keyhole. I'm on the orbital rim of the keyhole and drop into it. I see right here, this is my target because I've already opened. I know where I want to leave that cuff, and I'm going to open right there. Now I have a nice cuff of muscle to sew back to at the end. My assistant lifts this up. I use a suction to also, not only to suction, but to help with the retraction where I need it. And I elevate this right up. Any comments, Aaron?
Yeah, one thing I would like to add is I like the way you're doing it, just to be very aware that you cannot go too anterior with this incision or a cut here in order to avoid the frontalis nerve. Obviously, you're posterior to that. If you have to leave a cuff with this one to leave more of the fat pad, that's reasonable. But I think as long as you don't go all the way to protect the frontalis nerve, I think that's maybe one nuance.
Thank you. And again, feel free to make any comments you want during this. I take this all the way forward to the keyhole, and you can even take this down a bit. And now watch this. I'm going to leave. I'm cutting this way. I've left a little cuff right here. I have temporalis, temporalis, fascia, and temporalis. I'm going to take these three flaps at the end with a stitch to close because my burr hole is going to be here, and I'm going to be able to cover that with some substantial tissue here to keep from getting the atrophy. I next put my fish hooks on the temporalis muscle, and after I put my one or two fish hooks on the temporalis muscle, I will get the bovie back and take this even lower. I do this, as I say, exactly the same every time. That bovie, the nurse just handed it to me because she knew it was coming next. Notice that I'm opening with my left hand. When I get under the microscope, I switch to right hand. It's just the way I've learned to do it. We tie a curlex to the foot of the bed to put these fish hooks on so you can get excellent traction on them to hold that temporalis back. So here's our keyhole. I want this muscle back as much as possible. If I need to look over the edge here from lateral side, I don't want a big bulk of muscle in my way. I'm less concerned back here. I'm really concerned more anteriorly.
Right, putting those fish hooks right where the keyhole is where the operative corridor is going to be the key. And I think, as you said, Troy, the fish hooks really work the best in this area.
So you see there's been very little, if any, bleeding. And here I'm just defining because I want to make sure that this is low. If I make my craniotomy and come back here, then I can't get subfrontal toward the medial side. I can get subfrontal maybe right here, but I'm going to be limited. So I'm going to make sure I have this exposure. Now, do I need to come way over here toward the midline? No. But I will make this flat, and then I'll start coming across around here. So first we're going to make the burr hole down here. You can use a perforator. I've got used to using an acorn. Now you can make a hole, and then you can get a kerosene punch and make it bigger. To me, that's a wasted step. I make the hole big enough with the drill to get my dental dissector under there to free up the dura. After the dental dissector, I take a Penfield 3, and I'm going to slide it all the way under here. This is where, in my opinion, the dura is most likely to be cut, is when you come up over the frontal lobe here. So I take this 3, I make sure it's curved up under the bone to really free the dura, and I'm going to slide it across. And see, I've freed up all this frontal dura here, and make sure you can't get very far down here, but I get a little bit of that freed up toward the sphenoid wing. Now we'll take the foot plate and swing it right around. Now the subtle point with the drill, look, I like to lean it way back, not forward. I'm using the toe of the foot plate up against the bone, and the heel of the foot plate is against the dura. And so the heel is pushing dura back, and the toe is against the bone, and it just goes right around. There's very little jiggle factor with it. I like just to make a smooth cut all the way around. Now I haven't made another burr hole, so I just twist this a little bit and it'll pop right out.
It's best to stay as low as you can and as anterior as you can, so you don't have to drill more bone later, don't you agree, Troy?
Yeah, so the lower you get, the more temporal exposure, and then you connect from here to there across the sphenoid wing, and then you pop it out. So let's see how we did saving the dura.
Works very well.
It looks like pretty good. You're always going to get your middle meningeal somewhere. Not always, but frequently, so you just coagulate it. Here I am stripping the dura extradurally off the frontal floor and the temporal fossa. We're very low on the temporal. I don't think we're going to need more bone down here. I like this technique of putting suctions as gentle retraction on the dura because it serves two purposes. Remember I said earlier, take the lexal and bite the temporal side first so that you can get that side of your blade to bite off the sphenoid wing. It's a big help if you take this bite first.
I think it's important to use the rongeur because it's so efficient, it moves you along pretty quickly, and I think I will find it helpful. We'll go back to our slides momentarily. Again, thank you, Troy. Troy, thanks for the great video. We really enjoyed all the pearls you included. Let's talk about the pitfalls of this approach, and every step, we can get into trouble.
just now view the transmastoid approach.
Okay.
We have here a presentation from the AANS, 35-year-old male who had the facial nerve weakness, grade 2 of 6 possible grades. And we can see here the large cholesterol granuloma, which is in the CP angle. This is where the symptoms came from, this facial nerve weakness and numbness. Okay, so they are trying to present us here their way of doing the operation of cholesterol granulomas. So we can see here the anatomy that we viewed before. The middle meningeal artery, trigeminal nerve, and now when we go here, we will see some interesting tubes that they use to relieve dural pressure due to the rise in ICP, intracerebral pressure, here because of this mass. That's not good. This is a critical condition in medicine, which needs a prompt reaction. So we can see here how this skin incision is placed around the ear. Okay, and now you can see here the exposure through the mastoid, as you saw. And we will start here where the dura is retracted, as we viewed in our anatomy earlier. So we are trying to get to the cerebellopontine angle. So that's the anterolateral side of the brainstem, where we will see our pathology. So it's enough just to open these membranes to endure the desolation that you see here, to try to find landmarks such as the greater superior petrosal nerve, which we viewed, and eventually we'll get to your pathology that you see. And I think this will be pretty easy to be recognized, because this is a cholesterol granuloma. Okay, so we can see here now how we open the cavity of this granuloma, and how the contents of this cavity, lipids, are going out. Okay, this is removed in this video by suction, which is the best method. If there is some harder particles, tougher, then you can remove them mechanically. You do not have to use suction. Okay, and now this is just the cavity. I noticed that our surgeons here in Zagreb are very perfectionist about this. They literally check the cavity, I don't know how many times, until they can understand the whole anatomy. And that this is Dr. Jurashin I was talking about, who is one of our great mentors and supporters here in Zagreb. And we often go to his operations and enjoy learning from him. And I hope that one day perhaps we will have his presentation here in this hall, because I think he's a great educator, who is how can I say it without being saying too much, like a father to us here. So this is just the removing of the residual necrotic tissue that was left in the cavity. Okay, and checking of the cavity, and this is how the cavity looks after the excision. Okay, now a little bit of bone removal just to see if there is a spread of this. And now they are performing their technique, their pearl. They're placing these dural tubes relieve the pressure and to allow for the secretion of the fluids that appear here to come after. We can see here, I think this is part of a muscle, maybe, or fat that they're placing to watertight, to close this water tightly to prevent any CSF leaks. And we can see here the post-op results. Very great video from the collection of the ANS, and I always enjoy to watch all of their videos, all the new ones that go out. You can find this on the ANS YouTube channel. So this is just taken from them. They own the rights. And now we will just take a few more seconds to present you our team for the next time. So this was the fifth lecture we had of this year. Not exactly the fifth. We had one more on the life of Harvey Cushing, which was performed as part of our special occasions before the holidays. And now we can see here what we will look the next time. You know, this looks so complex, but if you look, try to understand what is happening here, you will see that you can recognize everything. So these are just ethmoidal cellular air cells. This is the eye, the optic nerve, the most anterior part of the fossa, and the orbital bone is drilled here. So this is the frontal bone. And here we can see the temporal fossa, which contains the temporal muscle. So you know, it's not that complex. Here, this is the trigeminal nerve. So we've been here, and now we're going to the front. We started with our posterior approaches. We moved through the temporal bone today, and now we are going to the anterior places where we are going to some of the most exciting parts. So I'm always trying to say them that they haven't seen anything yet, but really when we come to the endoscopic approaches, endonasal approaches, to the maxillofacial part, we'll see how all of this comes together, and I think it really provides you with the understanding of the anatomy. It really learns you how to know about this. So I would like to conclude with this, and in our last slide, as we can see here, we can just see who made all of this. This is my name. That's not important. Who I was your presenter. This is all part of the project of the Student Society for Neuroscience. It was my idea, but these people allowed me to perform it, and to perform it here in this beautiful hall of the University of Zagreb Medical School. Institute for Brain Research. So I'm indebted by our university also, and our medical school, and also to people who brought this to all of you who are watching this worldwide. So these are John Benet and Simon R. Downs from theinternetmedicine.com, and we have such a great collaboration. These people are so fascinating in their simple and brilliant way of doing these live sessions that I have only admiration to express. And also, of course, everything of this is dedicated to Professor Emeritus Albert L. Rotten, who made all of this possible, because I think in my sole opinion, I think he's the best living neurosurgeon today, and one of the people who won the Nobel Prize in neurosurgery, and that's the medal of the WFNS, the World Federation of Neurosurgical Societies. So I think that Professor Rotten provide neurosurgery with new life, and that his work is the ground zero of the modern neurosurgery from 2000 year when his book was published till today. And also to the ANS who inspire me and everyone around the world with their availability of their videos. So they made it all publicly available, and I invite you all to view their videos. Also, Dr. Gadol and the others who mentioned today, and of course of Dr. Bennett and Simon. Okay, so thank you very much. Can you now please take over, Dr. Bennett?
Slaven, thank you very much for an excellent presentation. Very professional, very good quality, and I'm glad to see this technology of Google Hangouts is able to bring a presentation of high quality to the internet. We will improve. I'm sorry about the technical problems that I caused. However, we'll get better, and we are not perfect. But I look forward to having more of these presentations from Croatia, and maybe even establishing a channel for neuroscience in Croatia, or who knows the direction. Simon, you want to comment?
Yes, thank you very much, Slaven. A fantastic presentation. I learned a great deal as a medical student myself, and a fan of neurosurgery. I can tell you that it was a great experience. I look forward to many more. Thank you very much.